This is now 909. Can we start, Bijan?
Yes, sir, you start. Already it is 909. So there are 23
Yes. This is more or less 10 minutes past 9. So, good evening, my dear friends, and my dear Bijan and Dr. Rajib, our speaker. And please listen carefully. We are now almost at the end of our online sessions. Bijan will say today perhaps 12th or 13th online sessions, and that will be talked by Dr. Rajib Bora, which are the changes in PIP and PIP. After the introduction of the Bijan, Dr. Rajib will continue his lecture. And Rajib, please make full slide of.
Sir, is my screen, sir, visible, sir? I have made full
screen visible. Make it full screen.
Okay.
Do double click.
Okay. Is it?
No.
Is it full?
No.
Before Rajib may few words about today's session. As sir has rightly said, today is the 13th talk of the series. And before that, we have almost completed all the talks. And today's topic is pulmonary graphics in mechanical ventilation. And by this time, we have already known what are how the babies on ventilator should be better if they are monitored clinically or by blood gas, etc. But there is another non-invasive mode of monitoring is pulmonary graphics. Nowadays, because of the advent of all this microprocessor-based ventilator, pulmonary graphics has come a big way. They said that pulmonary graphics is nothing but a computer without a screen. Many of the complications, what we have seen or what we have observed during mechanical ventilation, that can be detected before it happens in clinical practice in pulmonary graphics. So whenever you are ventilating a baby, always look at the screen. Looking at the screen, you will get many ideas. One of the most important utility of pulmonary graphics is that you can monitor a baby on mechanical ventilation. You can see the misadventures. Also, you can diagnose something. And second important thing is that you can see the response to the therapy like bronchodilator, etc. So pulmonary graphics is one of the important tools in the monitoring of newborn babies on mechanical ventilation. So I will not talk much detail. Today's speaker is Dr. Rajib Bora. Rajib is a DM from this side in India. He is currently working in Bhagirathi Neonatal Hospital, Guwahati, as a chief and HOD of the Department of Neonatology and Pediatrics. Rajib is an excellent speaker. So without wasting time, I request Rajib to start his talk. Rajib.
Sir.
Now it is full screen. It's okay.
And now is there? Okay.
Yes, it is full
now,
screen.
sir, it is full screen. Okay.
Sir, yes.
First of all, sir, thank you especially to Bijan sir, Sudhendu sir, and all the organizers for giving me an opportunity to be a part of this wonderful effort that you have all taken. So most of the talk on neonatal ventilation have already been done till now. It was from knobs to modes to even to high frequency. The speakers have talked about. Today, my job will not be on much of the numbers, but this presentation will be mainly about pictures. So I'd like to start it. So first, the first trial or the first try, people tried to find out the relationship between pressure and volume way back in 1929. Then this effort continued to happen, but it was only in 1990s that neonatal ventilation probably So after all of those efforts, it was mostly in 1990 that the neonatal ventilators first started to display those graphics on a scale, on a breath-to-breath basis. So it was mostly after 1990s that we are able to find those graphics on the neonatal ventilator screen. So what are the principles of pulmonary graphics? There is a lot of engineering that goes into it, and we must be thankful to our engineer friends that have developed the softwares and all for which we are being able to see it so easily. So we'll not be going into the intricacies of how these graphics come. It is basically that the signals come out from the patient, then it is received by the ventilator, and then we get to see it on the screen. This is what is pulmonary graphics. And for that all to happen, for the machine to understand what is happening with the patient, the most important point is your flow sensor. So if the flow sensor is not working in a particular machine, then there is no point of, means there is nothing to do about graphics and all, nothing will be displayed apart from probably the pressure curve. So while ventilating in neonate or any patient for that matter, we must be sure that the flow sensor is working properly. So since we are dealing with graphics today, so what do you see in the graphic screen? This is how we see it on the monitor when we ventilate a patient. Left side of the screen is your measured values. Bottom of the screen, the values that are set by the operator. In the center of the screen, this is what graphics look like. So it could be scalars, it could be loops, it could be anything. That is not the main point, but the, the whole screen looks something like this. Okay, then why these graphics are important and why this talk has been given to me? Because when we set certain settings for the patient, then we must know whether there is improvement or not. And we also should know that because of those settings, is the patient being harmed? Is there any complications that is happening? And lastly, if everything is going fine, we must know that yes, the patient is ready to win. So all of these things are important, and graphics help us to understand these things better. Now, pulmonary graphics, what are the types? So those who have been dealing with graphics and those who are new. So what is the most important thing is that we first need to make it easier for us. There are a lot of graphs available. So we should be 100% sure that we are dealing with only these 5. What are these 5? There are 3 scalar waveforms. These are also known as scalars or waveforms. These are 3 in number, and loops, these are 2 in number. So total 5. What are the scalars? Pressure time, volume time, flow time. And these show the relationship between the respiratory parameters with time. So time is constant here. And it displays on a breath-to-breath basis. And when these parameters are compared with each other, what we get is a loop. So this is the first basic understanding. So here we can see on the left-hand side, these are your scalars. This is your pressure time. This is your flow time. This is your volume time. So what we can see it is only in the flow time that there is a negative deflection. Apart from that, you can see all are above the 0 level. So this is one important point, because just by seeing at the monitor, we know that this is a flow time scalar curve. Loops, pressure volume loops something like this, and the flow volume looks something like this. We'll be discussing all these things in details later. So the basic understanding is that this should look something like this. Another important invention is that these softwares let us and help us to know whether the breaths are patient initiated or machine initiated. So how it is done? In most of the modern ventilators, inspiration, if it is machine initiated, it is generally shown in red. And if it is patient initiated, it is generally shown in yellow. On the screen, you can see this is red in color. So these are all machine initiated breaths. Again, sometimes the device may do auto calibration. At that time, a green line might appear. So how it helps, by only looking at the color, we can know whether it is a machine initiated breath or a patient initiated breath. So Waveforms relate changes in parameters with respect to time, and loops parameters presented relative to each other. So when we look at all these graphics, first thing is that first the student or the new beginner always finds it very hard to interpret these findings, and ultimately they stop using it. But the basic idea of this talk is that we need not go into the details of how these curves were developed, why these curves look like this, why it doesn't look like that. Basic thing is that it's all about pattern recognition. If we see normal loops and normal curves every day, then we'll understand that yes, there is something abnormal with this pulmonary graphic. So it is all about pattern recognition, just like amplitude integrated EEG. Those also you did not know all the intricacies of how these waves develop, but we need to know the normal patterns. Okay. So now we will discuss each scalar and each loop one by one. First, scalars. This is the volume waveform. Looks like this. It has your point A represents your start of inspiration, then point B represents the maximum inspired gas, and point C is your end respiratory volume. So your volume time curves look something like this. What we can see here is that there is a gap here, as you can all see. Why this gap is happening? Because there is always some amount of leak that is happening around the endotracheal tube. So the expired volume is always less than the inspired volume. So this is something that we need to keep in mind, because if this distance is more, then we know that the leak is also more. But normally also, this line is little bit raised from the baseline. Now coming to the pressure waveforms. Pressure waveforms gives us a lot of important information. We all know that MAP is area under the curve. What is MAP? PIP into TI plus PEEP into TE divided by TI plus TE. We all know that formula, but by looking at the curve, we can know what is the MAP in this patient. We can also know the amplitude by dividing PIP minus PEEP. We know what is the amplitude in this patient. So from a simple pressure time graph, we can have idea about the map that the patient is receiving. And this is something known as plateau pressure. It generally happens in pressure control ventilation. This sort of it comes when it is time cycled. When it is time cycled, TI is set by the patient. So till that TI is reached, once the PIP is reached, you get a plateau. That pressure is hold for that time. So it is known as plateau pressure. So these are certain informations that we get from the pressure time scalar. Okay. By looking at the shape of the pressure scalar, we can know whether it is a pressure controlled or a volume controlled ventilation. Since it is pressure controlled, so it is square shaped. Others are not square shaped. In volume control, flow is square shaped, others are not square shaped. So even if we don't look at the mode that suppose your friend has said, just by looking at the monitor and looking at these pressure curves, the shape of these pressure curves, we can know whether the patient is undergoing pressure control ventilation or volume control ventilation. Another important information that we get is that, as I told you, pressure, this is positive pressure ventilation, so always above zero. But when we get something like this, we know that there is some sort of a triggering that is happening in the patient because of negative intrapleural pressure. So in the scalars, if we find that before the initiation of the next breath, if there is a dip like this in the negative direction, then we know that those breaths are being triggered by the patient. And in a control breath, that dipping is not available. So that can also be known. And we can know that yes, the patient is triggering the ventilator. So by looking at the picture, we can see that whether here PIP is 20, when the PIP is set to 30, this height increases. Now suppose PEEP. This is PEEP 5, this is PEEP of 10. So looking at this one, we can know that yes, the PEEP is here less, PEEP is here is more, and compared to this curve, the PIP is more. So these are certain basic things that we can, just by looking at the screen, we can know. We can also know that what is the effect of the change in the TI if we have done. Suppose we have increased the TI. So before, if it was looking something like this, once the TI is increased, then because this inspiration time is increased, so this rise is also increased, and ultimately the map that we get also increases. So if we don't look at the graphs, then whether the TI has really reached the patient or not, we won't be knowing. But by looking at this, you see here the slope is less, here the slope is more, and you can see that the time taken for the TI is more here than this. Now coming to the next waveform. The next waveform is the most important and also the most complex. It is the flow waveform. Similar, as I told you, in volume control, it is square shaped, but in pressure control ventilation, it is not square shaped. It is called as variable decelerating flow. Okay, so this is pressure control and this is volume control. You can see this is square shaped in volume control, but not square shaped in pressure control. Next important thing, these flow time curves have 4 phases. One is your initial accelerating phase during inspiration, then it reaches a peak flow rate, then it decreases in the inspiration, that is deceleration in the inspiratory phase, again it accelerates in the expiratory phase, then it reaches the peak expiratory flow rate, and again it reaches the baseline by decelerating to the baseline level. So there are 4 stages, 1, 2, 3, and 4. So why these are important? If something is less or something is narrow or something has less height, then we can know that yes, there could be interference in the flow, whether it is during inspiration or during expiration, as we'll note down in the next few slides. Okay. So how this flow waveforms looks in different conditions. Now, since we have seen the normal one, not just by looking at this picture, we can see that this expiratory phase is taking more time to complete. So what it means that there is some sort of a resistance in the expiratory flow. So that resistance ultimately leads to your less peak expiratory flow. Also, the time taken to reach the baseline is more. So by looking at this picture, we can say that there is some sort of expiratory resistance that is happening. What is the cause? That is another matter. We have to look at the whole picture, but by looking at the graph, we can know that yes, there is some sort of an expiratory resistance that is happening. Second, gas trapping. As you can see here, before this expiration finishes, the inspiration is starting. So you know that the expiratory flow here is less than the inspiratory flow. That means some amount of gas is being left behind in each breath. That leads to your gas trapping, and ultimately that is also known as your auto PEEP. Now, by looking at your flow time curves, we can also know what is the cycling mechanism. These have all been dealt with in the previous lectures, your modes, your triggering, your cycling. So it could be either time cycle or flow cycle. So time cycle, inspiration has to happen for a set period of time, set period of TI. Flow cycle, there is no such thing. Once the flow decreases to a certain amount, that is also known as the termination sensitivity, that is usually set at around 5 to 25% of the peak inspiratory flow, then the machine means cycles into your expiration. So there is no such time because this is flow cycle and not time cycle. So it depends on the flow of the patient and not on the time. So here, this is the simplified picture. Here you can see, if we see a flow time scalar like this, where there is some sort of an inspiratory hold, because the TI is not being reached up to this point, so we can know that this is time cycle. But if we do not find any sort of a gap and your inspiratory flow is directly converting into your expiratory flow, then we can say that probably this is flow cycle. So that is how it can help in knowing the cycling mechanism that is going on. So not only the flow curves, even in your pressure curves and in your volume curves, if there is some sort of an hole like this, you know that probably this is time cycle, and if there is no hole, then probably this is flow cycle. Then by looking at this flow waveforms, you can see in this picture, here the inspiratory phase has not finished, but the expiratory phase has started. So what we know is that we have not given enough time for the inspiratory phase to finish. So probably there is decreased inspiratory time that we are giving. So we need to probably increase the inspiratory time. Here, what is happening? The expiration is not finishing, but the inspiration is starting. So we know that probably here we are not giving enough TE, that is expiratory time. And because of that, there is gas trapping, and that is leading to your autopip. So suppose we have set a parameter. By looking at the X-ray or looking at the ABG, we cannot tell that whether the TI or the TE that we are giving is appropriate. But as we can see here, by looking at these graphs, we get an idea that the parameters that we have set is really benefiting the patient, or do you need to modify something in these parameters? So this is how it helps. Next important thing is auto triggering. This auto triggering, the machine thinks that the patient is triggering and the more breaths are being delivered. So that could be either due to leak, if it crosses the termination triggering sensitivity, or it could be due to rain out or secretions in the circuit. So all these things could lead to misinformation to the ventilator that the patient is triggering, and it ultimately gives a breath. So why that is important to avoid? Because that can lead to hypocapnia as well as the risk of lung injury. And whether it is auto triggering or not, or spontaneous breath, how we can know? We can see here that these breaths are relatively uniform. So in spontaneous breaths, these are not uniform to such a level. So by looking at the picture, we can say that probably auto triggering is happening. Then we need to look at the leaks, we need to look at the secretions and do the corrective measures accordingly. Now coming to loops. So now we have talked about pressure, volume, and flow time scalars. Now loops. I have told that there are two loops, so we'll be discussing one by one. First is your pressure volume loop. So this is one loop that is very commonly asked, and people also tend to rely much on this curve. So we'll be knowing in details about this loop. First is your inspiratory limb. This is your expiratory limb. Then this line that connects this point to your PIP is your compliance axis. Then the line drawn from the midpoint of your inspiratory limb to the compliance axis is your inspiratory resistance, and the line drawn from the midpoint of your expiratory limb to your compliance axis is your expiratory resistance. And if we draw a line like this, then this area gives us an idea about the work of breathing. So these are certain things that we need to know, because while interpreting these loops, we need to be aware of where is the compliance line, what is the meaning of this resistance, how work of breathing increases or decreases. Okay. So, and another thing, in this pressure volume loop, there are certain points known as your inflection points. This is your lower inflection point. This is your upper inflection point. Again, this is also your critical opening pressure. This is your critical closing pressure. So all these things we need to keep in mind. So if we increase the PEEP, we can see here that this loop is moving towards the right. And if the opening pressure is far away from your PEEP, then that is bad for the lung. So we need to keep this opening pressure as close to the PEEP as possible. So these are certain important things that we need to keep in mind while looking at your pressure volume loop. So compliance axis. So how that helps? As I told you, suppose this is your compliance. This is your compliance axis. If we find that it is moving like this, that means the line is moving towards the right. That means your compliance is bad now. So our idea is that if the loop moves towards the right or the axis moves towards the right, we say that the compliance has deteriorated in that patient. So this is by simply looking at the position of this axis, we can say whether the compliance is good or the compliance is bad. Work of breathing, I have already told that we can we need to draw a line to your inspiratory limb, and then this area gives your work of breathing. So why that is important? Because if there is increased work of breathing, more pressure must be applied to achieve the same lung volume. So this is your volume, this is your pressure. So if your work of breathing increases due to any problem in the mechanical properties of the lung, then definitely the more pressure will be required to achieve the same amount of volume. Okay. So in your pressure targeted ventilation or pressure control ventilation, your pressure remains same, but your volume differs depending on the compliance of the lung. This we all know. So your curve will look like this. Pressures will be same, but the volume will either increase or decrease depending on the mechanical properties of that lung at that particular point of time. Volume targeted, here the volume will remain same, but the pressures will differ. So how it can be helpful? Suppose this curve was here, now this curve has moved here. When we are giving suppose volume guarantee ventilation that we all now most commonly use, there we can say that yes, probably the patient is getting ready to be extubated. So this is how it can help us to know about the auto-weaning that is happening in the patient. Third important thing in this curve is your hyperinflation. Hyperinflation, C20 by C, these are all very common terminologies that are used, and we need to be clear regarding these things. So basic thing is that once this lower inflection point is reached, if we give little amount of pressure, the volume will increase significantly. So this volume will keep on increasing, but definitely it cannot increase beyond a certain point of time. So suppose we have given this much amount of pressure and we have achieved this much amount of volume. But from that point, if we keep on increasing the pressure, it is not going to result in a significant difference in your volume. So the volume will almost remain same or there will be minimal change in volume, but we are giving unnecessary pressures to that patient. So ultimately, it will lead to your hyperinflation, also lead to your injury to the lung. So we need to be careful. So what it will look like? It will look like this beaking. So if we find in a pressure volume loop that there is some sort of a beaking like this, that means your compliance was moving like this. Now it has moved like this. Then we need to come down on the pressures or the volume as appropriate in that particular mode or particular patient. So we need to avoid this sort of a picture in a pressure volume loop. So if this was going in a straight line, C20 by C basically means your compliance of your last 20% of your breed compared to the whole breed. So if this line was going like this, the ratio would have been 1 by 1. But since this line has moved like this, the ratio is now less than 1. And it is said that if it is less than 0.8, then there is hyperinflation and we need to come down on our pressures. So that is why looking at this beaking is very important while dealing with your pressure volume loop. So this one I have already told, we should not allow any beaking to happen. And in fact, in modern ventilators, we also get the values that are numerically presented in the screen. You can see here, C20 by C is almost around 8. So probably there is hyperinflation and we need to come down on the pressures in this patient. So this, we can get so much of information by just looking at the pressure volume loop. This information we cannot only by looking at the X-ray, probably it will not be possible. Okay, so I have already told that your critical opening pressure needs to be closer to the PEEP as possible. Otherwise, there will be your collapse of the alveoli, which will lead to atherectotrauma. So this is a better picture where your opening pressure is closer to the PEEP or the lung has achieved appropriate FRC in this patient, but there is less FRC in this patient. So by just looking at the picture, we can say that it is taking so much of pressure to increase volume. Probably we need to increase the PEEP. Another thing that is also important is knowing about the pressure overshoots. So if the flow rate is given at a very high speed or a very rapid rise time, then we get what is known as notching in the pressure curves. And also there is again this uprise in your, when this inhalation phase in flow curve is going to finish. So these sort of pictures we get, one is this, and one is this notching. So this are also can be seen in your loops. Your notchings can be seen in the loop. So there should not be any notching. If we find this sort of pictures, then we need to adjust our T rise time. So that option is also available in most of the ventilators, where you can adjust the T rise time so that these notchings can be minimized, or so there should not be any notching. So if we find a spike sort of a thing, so that, which means that probably there is very rapid rise in the flow rate, then we need to come down or adjust the rise time so that the curves become smooth as on the right side. Air hunger. If the delivered volume is inadequate, suppose we have given only 4 ml per kg, but the patient needs 6 ml per kg, then your pressure volume loops will look like this, figure of 8. So if we find something like this, probably we need to increase the flow, volume, or TI. So those things, we need to decide bedside which parameter will help most. But if we find something like this, we know that there is air hunger and we need to increase the air entry in that patient. Now I showed you this picture. You see here there is a figure of 8 on the top. If we find something like this at the bottom, it means there is trigger asynchrony. So either we need to increase the trigger sensitivity or decrease the trigger sensitivity. But how to know? There is no other way, only by looking at this pressure volume loop. If we find something like this happening at the bottom, then we can say that probably there is some adjustment that needs to be done in respect to your trigger sensitivity. Now I was talking about resistance. I told you that this one is like this, your compliance axis. As the distance increases, your resistance increases. So if there is bowing like this, it means there is more resistance. If there is bowing on the inspiratory side, more inspiratory resistance. If there is bowing on the expiratory side, that is more expiratory resistance. Why that is happening? There could be many causes, like endotracheal tube could be kinked, obstructed, probably suction is needed, probably bronchodilators will help. So all those things will depend on the pathophysiology of the patient, the state of the patient. So those things will be decided. But if we find something sort of a bowing, then we can know that yes, probably the resistance is more either on the inspiratory side or on the expiratory side. So as I told you, bowing on the inspiratory side, increased inspiratory resistance. Bowing on the expiratory side, increased expiratory resistance. BPD, what could happen? Initially, the baby could be normal, suppose on day 2 requiring PIP of 13, then slowly on day 8 required PIP of 16, and you can see there is a bowing on the inspiratory side, meaning increased inspiratory resistance. Then finally on day 28, there is bowing on both the inspiratory side as well as on the expiratory side, meaning that probably there is both now inspiratory as well as expiratory resistance, as typically happens in late cases of BPD. Leak. Whether leak is happening or not, nowadays modern ventilators does display in a numerical value, but still by looking at these loops, we can see, yes, this expiratory phase is not finishing where it started. So probably it is a broken loop. So probably there is leak. Surfactant administration, how it helps? Before surfactant, the compliance was low. After giving surfactant, your compliance increased. As you can see, now it is moving towards the left. So compliance has increased. So during pressure control ventilation, it is very important, because as this compliance increases, if we do not decrease the pressure, that will lead to your pneumothorax. We all know that. But how to know that? There is probably no better way of knowing that other than looking at these loops. By looking at the loop, your baseline loop, if it was looking something like this, after giving surfactant, if the loop is improving or the axis is moving towards the left, we need to come down on the pressures. This, we are benefited in volume guarantee ventilation, because that does auto-union, as we already told. So volume is guaranteed. But in pressure control, since many people are still using pressure control, there you need to come down on the pressures once the compliance increases. So this is even more important for people who are using pressure control ventilation. Auto PEEP. So I told you auto PEEP, how it looks like in your flow curves. It doesn't reaches the baseline. Then again your inspiratory phase. But in loops, it looks something like this. So as there is more air trapping, So more auto PEEP happens. So this compliance or the PV loops slowly and slowly shifts towards the right. So more PEEP is here. So all these are auto PEEP. Now coming to your last graphs, those are your flow volume loops. Flow volume loops, again, like your scalars, there will be an inspirated phase, peak inspiratory flow rate, decelerating phase, accelerating phase in your expiration, leading to a peak expiratory flow rate. Again, this will slowly decelerate to your zero level. So this is how a flow volume loop looks like. Okay. So if there is an extra thoracic obstruction, how to remember? This is not E for E. E, you can say E for I, means opposite. So if there is an extra thoracic obstruction, your inspiratory loop, here, this is your inspiration loop, and this is your expiratory, your limb in your flow volume loop. Though in different machines, this could alter, but still for this discussion, this is inspiration, this is expiration. If there is flattening, there was bowing in those loops, in your pressure loops, pressure volume loop, but here there is flattening. So if there is flattening in your inspiratory limb, that means extrathoracic obstruction. If there is flattening in your expiratory limb, that means intrathoracic obstruction. There, so EI is opposite. Okay, so now we'll just, and if there is fixed, then both will be compressed, both your inspiration as well as expiration. Or there could be some sort of a scooping like this. So these two pictures could be present in fixed airway obstruction, like in cases of BPD. Okay. So how does bronchodilators can help? How you can know? Suppose this is a fixed obstruction, both inspiratory and expiratory compressed, means resistance is the obstruction in there in both. So after giving bronchodilator, we see these loops are opening up. So probably there is improvement in the patient. So this is how we come to know. So resistance, as I told you, expiratory resistance different in your PV loop and flow volume loop. In PV loop, expiratory resistance means bowing of the expiratory limb. Here, flattening of the inspiratory limb. So this is how it, both are a little bit different. So we need to keep that in mind. Inspiratory, bowing of the inspiratory limb, bowing of your inspiratory limb, but your here inspiratory limb, your flattens. Okay. So what we need to do probably in this, if there is suppose increased inspiratory resistance, we can increase the TI, we can increase the PEEP, and we can see whether these loops are going back to their normal size or not. This is another picture that we often see if we start using pulmonary graphics. If we see this sort of staggering sort of thing, then probably we know that there could be some sort of your condensation in the circuit or increased secretion in the ET tube. So this sort of pictures, staggering or jaggering or serrated waveforms suggest that secretions are there, probably in the airway, sensor, or the circuit. So leak in this full volume loop, the expiratory limb does not reach your baseline. So there is a gap, and this gap is your leak. So how it differs? In your flow volume, it was looking like this. There was a broken lip, and here also it is not reaching the baseline. So these two pictures will see if there is a leak in two curves. So we need not confirm by only looking at a pressure volume loop. We need to look at both. If both are looking something like this, then we can be 100% sure that definitely there is leak. Where that leak is there, that one we can decide afterwards, but we'll know that yes, leak is there. Okay. So flow volume look, how air trapping looks. So I have shown previously different pictures of air trapping in different scalars and loops, but here your air trapping will look something like this, where your expiration is still continuing. It has not reached the baseline, means there's some sort of air that is being trapped. Suddenly, if we see that the inspiration is finishing like this, there is no expiratory limb at all, that means the patient has accidentally extubated. So how it can help? Suppose the sister calls us that the patient is desaturating. And we have a doubt that the patient may extubate. So instead of putting the laryngoscope inside or seeing by different ways, by only looking at this flow volume loop, and if we see this sort of a picture, we can be 100% sure that probably the patient is extubate. So these are different ways in how these graphics help us. Okay. So in different situations, patient ventilator asynchrony. Suppose the expiratory limb in your flow time graph has reached, but then again it has not transformed into your again the next breath. So you can say that probably there's some sort of ineffective triggering that is happening. Probably we need to deal with the triggering sensitivity and all. We need to either decrease or increase so that this becomes smooth as shown before. Auto triggering, as I showed you on the flow time graphs, it looks something like this. So it will look something like this, but in case of your pressure curves, normal trigger, as I told you, there is a negative dip because of negative intrapleural pressure, but auto trigger will look something like this in case of your pressure curves, but in case of your flow time curves, those will look something like this. So different ways in how these curves look, but the meaning is same. So we need to have these curves in our mobiles, specifically named in different names like auto triggering, how it looks in that loop, that so that we can compare and see. Otherwise, sometimes it may be difficult for us to interpret because it looks different in different your scalars and loops. Breath stacking, how can you know? Suppose this breath interval, this one, again suddenly another breath has come. So by pressure curves, it looks something like this if there is breath stacking. Also, that is also known as double triggering. So in flow curves, again, there will be some sort of a picture like this. So that means that probably there is breath stacking. And so that could lead to either overdistension or trauma. And it could be caused by either low tidal volume, short TI, or low flow rates. So we need to look at all these things and then need to look again at your curves to see whether whatever manipulation we have done that has resulted in normalization of the graphs or not. So termination asynchrony, as I told you, that was there in the flow curves. So here you can see premature cycling looks something like this. Delayed cycling. Suppose this patient should have come like this. Now it is again going up, not coming down. So probably there is delayed cycling in this patient. How that can help us in how flow versus time can help us in determining choosing TI. You see, this is a normal. Inspiration ends, expiration starts and finishes. But here you see, before the inspiration has ended, expiration has started, which means there could be a short TI. That could also lead to your, and here you can see that the inspiration has finished, but your expiration has not started yet. So that could mean your long TI. So by looking at this flow time scalar, we can decide or choose your appropriate TI for that particular patient. So ultimately, why we are looking at these graphs? So our main ideas are that by looking at these graphs, if we find something abnormal, so that we can troubleshoot. So how can those be done? Suppose there is air trapping. Then air trapping looks like this in your flow time loops. Air trapping looks something like this in your pressure volume loop. And air trapping looks something like this in your flow volume loop. So I have just brought these pictures together so that to show that how the pictures differ, but the meaning is same. Gas trapping, again, I told you that it looks like this in your flow time scalars. So what we need to do in that case, decrease the ventilatory rate, decrease the flow rate, shortening the inspiratory time, increasing the PEEP. So probably some of these parameters will help, but first we need to understand that there is gas trapping, where the importance of graphs come, and then seeing at this picture, we need to manipulate these settings. Increase resistance, as I already told you, this is the same picture, just to bring it all together, I have shown it again. Decrease compliance, we need to treat the cause and increase the PEEP. Increase compliance, aggressive weaning of pressure need to be done as after surfactant administration. Turbulence looks like this. Also, in your flow time curves, turbulence also has this sort of speckled appearance. So even if you don't go see the loops and you find something like this in the flow time graphs, then also that could mean that there could be excessive secretion. Change the circuit or move the endotracheal tube. So we need to look at all these things, but if we see this sort of picture, we know that yes, there is some sort of an obstruction. And this sort of an information from these loops have been used by certain institutes now to determine when to suction a mechanically ventilated baby. As we all know, newer guidelines say we don't need to routinely suction a baby unless and until there are visible and disturbing secretions or thick secretions. So that also will require close monitoring. So by looking at the loops also, we can understand that probably there are secretions and we need to suction this baby now. And this has been utilized by some institutes. Over distension already discussed. So what we need to do, we either need to reduce the volume in volume ventilation or reduce the pressure in your pressure ventilation. But we should not find any sort of beaking in your loop. This is what is the important message. Leaks, PV loop looks like this, and flow volume looks like this. And as I told you, though there is some sort of gap between this line, but if you find that there is increased gap in volume time, that can also indicate your leak. And it can also look something like this. Suppose this blue, as I told you, blue means exhalation, but before this blue is coming to the baseline, your next patient has started your next breath. So means your expiratory volume is much less than your inspiratory volume, which also means your leak. So as I told you, sister calling you, patient is desaturating. If you're suspecting extubation, look at this flow volume loop. It will look like this. There will be no expiratory component at all. It will also look like this in your flow. It will look like this in your pressure. And if you look at your this one, it will look something like this. And there will be no expiratory component in your pressure volume loop. So how all these pictures can help us to know, yes, the patient is extubated. We can also identify the modes by just looking at the picture. If we find that, yes, the pressures are always same, probably this is a pressure control mode. If we see that the pressures are differing, probably this is a volume guarantee mode. SIMV mode, mechanical breaths have more height. Patient triggered breaths have less height. And how that helps? Because we know that when we give pressure support in case of SIMV mode, our idea is that this should be 2/3 of this height. So if suppose the patient breath is only this much, so this is not adequate. So we need to go up on our pressure support. So how we can, so only by setting suppose PS of 8 or 10, if we look at these pressure loops, then if we see that the spontaneous breaths have very little height, then probably we need to go on our pressure supports. And this is a very common issue that we also encountered during our student days. A patient suddenly starts having tachypnea and retractions, and the pressure, your time loops drops down, but other two curves are normal. Then what we understand is that probably the patient needs more volume. That is why the patient is having significant tachypnea and retractions. And same picture, if we find that the patient is completely comfortable, then probably in a volume guarantee, volume targeted ventilation, then we know that probably there is auto weaning that is happening. The patient is not requiring enough pressures to give this amount of volume. So we know that the patient is ready to extubate. So same picture in different clinical circumstances can mean different ways. So graphs are not the only thing. Definitely we need to look at the whole picture. So what we have learned, that these graphs identify pathophysiological processes it recognizes patient's response to therapy and monitor patient's disease status. We can calculate the mechanics, optimize settings based on those graphs. We can determine the effectiveness of our next settings, whether the modifications that we have done is helpful or not on a breath-to-breath basis. We need not wait for an X-ray or an ABG. It detects adverse effects of mechanical ventilation, like looping can suggest your hyperventilation. Then ultimately it leads to minimizing the risk of injury to the lung. So the newer machines also have these trend screens. So suppose you are going for a morning round and you don't know what happened last night, and your resident has told that, yes, something happened at around 2 o'clock. So we can open this trend screen and look what exactly happened at that time. So by looking at this and comparing your volume at that particular time, your rate, tachypnea was there or not, then you can understand. If the volume has suppose decreased and the tachypnea has increased at the same time, probably there was lowest volume that was delivered to the patient. So this is how a train screen helps. It helps us to reconstruct past clinical events and also enables us to follow changes over time. But graphs, obviously, like every other thing in this world, is not without limitations. So what are the limitations? We also need to keep that in mind. Neonatal lung needs to be uniformly inflated if pulmonary graphics is really to represent real lung function, but that is often a difficult task. So neonatal lung is not always uniformly inflated, so interpretation could be erroneous. Transpulmonary pressure, we always know, is the sum of your positive pressure plus your negative inspiratory pressure, but this negative inspiratory pressure is not measured by standard ventilator mechanics, and therefore in actively breathing infants, the values that we ultimately get may not be 100% accurate. If a substantial leak exists, measured values definitely will be inaccurate. Again, non-homogeneous lung disease, very common in neonates. In those sort of situations or in melasic airways, graphs may differ, or we may not know whether that particular graph that we are getting, whether that is representing which part of the lung. So that is another important point that we need to keep in mind. Another thing is that before interpretation, there should be proper scaling of axis. Modern ventilators probably do that for us, but if that is not done, we need to first do proper scaling so that everything is visible in the loop or scales, or so that before interpretation, we should look at that as well. And as I told you, sometimes these flow volume loops, this may not always be inspiratory. Sometimes in different machines, this could be inspiratory or this could be inspiratory. So we need to know about the machine that we are using. So what is the final message or the interpretation finally is that pulmonary graphics is only one piece in the puzzle. It is only one part. Only looking at the graphics cannot help, as also I have shown in a few examples. We need to look at the history of the patient, the clinical picture, ABG, chest X-ray, and also we need to know the pathophysiology of the lung. Only then we can make use of this beautiful pulmonary graphics to help us manage our babies. So graphics, we need not be too terrified by looking at all these loops and scales. We all should know these graphics are all about pattern recognition. If we look at it regularly, then we know what is normal. Then if we find something abnormal, we compare it with the pictures that I have presented in this slide. Then we can move forward to do our maneuvers or to adjust our settings. And finally, one size does not fit all. So we need to look at the whole picture. The same settings may not work in all. The same graphs may have different interpretation in different babies. So graphs can only help us, but it is not the only solution. So our final goal is that there should not be ventilator-induced lung injury, but actually it is physician-induced lung injury, not ventilator-induced, because we are the ones who are probably not ventilating it properly. So how to ventilate it properly? Make use of your X-rays, ABGs, your clinical decision-making power, and also your graphs to help us ventilate the babies better. So now we cannot run away from technologies. Technology has crept into every part. We know how DRS review system in cricket has helped us in making the erroneous decisions now into correct decisions. May not be in 100% cases, but definitely it has improved from before. So what pulmonary graphics does for us is that it translates the good judgment to informed judgment and better patient care. So thank you, sir.
Thank you, Dr. Bora. Now, Dr. Bijan, please.
Thank you, Rajib, for the excellent presentation and the very simple way of explaining all the graphics, more the pressure and volume, pressure against time, flow against time, volume against time, and the flow loops and the pressure volume curve. Some of the important take from his presentation is that most of the monitoring system that we have our clinical practice, these are our snapshot. Like you take an ABG, you take an X-ray, these are all snapshot. But when you are actually observing graphic, it's a real-time display of what is happening to the baby. But the most important thing, as he has rightly pointed out, if you do not see these graphics daily, if you know your ventilator, know your device, you will not you will not be able to understand what is happening to the baby. Even there is some changes in the graphics, we will not be able to pick it up. That is why every day you have to go to the baby and see what is happening to the baby. And these graphics has to be interpreted in the context of the baby's clinical pathophysiology of the lung. And that pathophysiology of the lung can be understood, you know the history, etc. As he has also rightly said that graphic is an add-on to the existing monitoring system that we have. It cannot replace your clinical judgment and other things. So it can be add-on with our whatever clinical equipment we are having. But what are the curves we have shown that maybe in one ventilator, different ventilator has got their different representation of their graphics. Like he has shown that red line may be the inspiration, but in some ventilator it may be the white line. In some ventilator it may be yellow line like that. So you have to know the machine and you see the manufacturer's recommendation and guidelines before you actually start interpreting your graphics. Third important thing is that in our clinical practice, most of us, you buy a ventilator, you don't know what you are buying. So always you take a demo and you try to understand what is there in their manual. So whenever you are buying a ventilator, see the manual, what is it in there, and accordingly you try to interpret. Because every ventilator has got its own way of explaining the graphics, the color coded and everything. Basic representation will be same, but some of the things may be different. So one issue, and he has rightly said that you take all the pictures with you whenever you are finding anything in the graphics and try to compare what you are having. Most important thing, all this flow and the volume, as we have discussed several times, in all ventilator, the flow sensor is the heart and mind of any patient ticket ventilator. See, if the flow sensor is not working, it will not be able to calculate the flow. And all these ventilator actually volume is measured by flow against time. Flow into time is equal to volume. So if your flow sensor is not there, this ventilator will not be calculate the flow against time. So there will be nothing will be showing in the flow curve as well as the volume curve. So it will be all meaningless. It will be IMB only. But unfortunately, most of the time in your clinical setting, many ventilators, many times we see your flow sensor is not working. One point to add, he was saying if you give surfactant, there will be suddenly improvement in the compliance, so your pressure requirement will be less. So in case volume ventilation, the pressure will be automatically be come down. So you don't have to change the pressure. But even in VG mode of ventilation, pressure may come down, but PWP will not come down. So you have to manually adjust the PEEP when you are giving surfactant to a baby. That requirement of PEEP will not be done by that PWP cannot be adjusted by a ventilator. So I think he has nicely explained all the things, all the details comprehensively about graphics. That now it is your time to use it. And once you start using it, then you will find different problems. You can correct yourself. You know what is the problem, what is happening to the baby. So I think we can take some questions. If there is some questions, you can write in the chat box, then we'll be able to discuss. Any questions from the audience?
Audience can unmute,
And ask question directly to
ask
us.
question directly to our speaker or Dr. Bijon for there any doubt regarding the graphic composition. Rajib, please put your first slide over here.
Yes. Sir, this one?
No. And first your name.
Oh, sir.
Now, if you have any question regarding neonatal pulmonary graphics, please,
I think
you can ask question directly.
it is an excellent presentation. I think he has covered everything of graphics.
Lovely
There should not be
presentation,
doubt.
lovely presentation.
There should not be any doubt amongst the audience, but it is the time for the audience to practice it. And once you start practicing, then only will be to know what is happening. Otherwise, it will be difficult.
Yes.
And in real life, when somebody is explaining, you think that it is very easy. But when you actually in real time scenario, you will seeing the screen, you will be confused. You will find everything is same. So unless you are very much into it, it will be difficult.
Yes, Dr. Bijon, you are 100% correct. When you have handled everything, you can't understand anything. You have to handle, you have to see the patients, see the ventilation settings and how it works. Then you will can understand, not by lectures, other things. Only practicals and practicals.
If there is no question, I will request all the participants to tomorrow you go to the unit, you see what is the changes graphic in the graphics and try to interpret on your own. Then only you will be able to understand and learn the things. Sir, if there is no more question, we can close the session tonight. Thank you, Rajib, once again. It was really enjoyable to see your presentation. The way you are just showing all the pulmonary graphics and their character, it was really wonderful. Thank you, Rajib. Keep it up.
Thank you,
Thank
sir.
you all the participants for being with us. Tomorrow we have got the last lecture. So good night and looking forward to see you all at the physical workshop on 12 and 13 and tomorrow also. Thank you. Good night.
Thank you, sir. Thank you, sir.
Okay, good night, everybody.
Thank you. Good night, sir.